Hello and welcome back to Physio Alchemy with another video. Today we are going to talk about or discuss about the differential diagnosis of your knee joint, because we have numerous kind of pathologies around the knee joint because it is a complex body joint. So that is why today we are going to differentiate some of the common pathologies. I have covered around 17 to 18 pathologies and how you can differentiate them from the sign and symptom of the patient and the chief complaint of the patient. So with this information you might have a good opinion on your patient diagnosis. So without any further delay, let's start the video. First pathology that we are going to talk about is your patellofemoral pain syndrome. Now you see, the patellofemoral pain syndrome and the chondromalacia patellae both are different things. Your PFPS is a generalized term that we use for the pain around the kneecap area, but if you talk about the chondromalacia patellae, that is because of the retropatellar pain. That means pain behind the patella whenever there is a destruction to the articular damage or articular cartilage damage is there between your patella and the distal femur. So now in patellofemoral pain syndrome, the common symptoms will be anterior knee pain will be there. Then we have is the pain on sitting for long hours. That is known as your theater sign. So when you go to the movies and you are sitting for 2-3 hours, and after that when the patient is getting up, in that kind of time the intense pain will be there at the anterior aspect of the knee. That is what we known as the theater sign. And then pain while climbing the stairs, there will be crepitus, so crepitus sound will be there, and mild swelling, so mild swelling around the patellar region. So these are the common signs that you will see in the PFPS. Then we have is the pain on the front of the knee. So in chief complaints, patient will complain you about the pain at the front of your knee that is worsening on during stair climbing and descending the stairs. At the same time, when the patient is doing certain kind of activities which involve your sit to stand, okay, so that kind of thing, patient will complain you pain. So this is the patellofemoral pain syndrome. The second pathology that we are going to discuss is about your patellar tendinopathy, which is also known as a jumper's knee. Now it is very common in the players or the athletes who are into sports activity. Now you see, the common symptoms will be localized pain at the inferior pole of the patella. Okay, so the localized pain will be there at inferior pole of the patella, and stiffness will be there after activity, especially your sports activity, and tenderness on palpation. So when you will palpate the entire length of your patellar tendon onto the anterior aspect of knee, you will see the tenderness will be present. Now the chief complaint will be pain just below the kneecap, okay, while jumping and running. So whenever you are loading the patellar tendon area, in that time you will have the pain. So it is not after the into the resting period, but rather than onto the sports activity duration. The next pathology is your quadricep tendinopathy. Now this is again very common in the people or the sports player who are not doing regular stretching and who are not into the warm up or cool down period. So in that kind of patients, you will see the quadricep tendinopathy will be there, stiffness. Now pain at the superior pole of the patella. Earlier it was pain at the inferior pole of the patella, now it is superior, and tenderness will be there onto the superior aspect, not on the patellar tendon aspect. Then we have is the tenderness, difficulty in squatting. So in these kind of patients, again there will be difficulty while doing the squatting as well as jumping, because the moment they will move on the squat, they need knee to flex down. Now during the flexion, if they have quadricep tendinopathy, so that tendon is in a chronic phase that will not allow to stretch, so again their pace will be reduced, so they will be having a little bit difficulty while moving into the flexion of the knee joint while doing the squat. Now the chief complaint will be pain above the kneecap during the activity. So again during the activity there will be pain whenever it is in the loading phase. Then we have a very common pathology, that is your meniscal tear. So it is very easy, mostly it is found in females. Now we have is the locking and catching. So whenever patient complains about the locking mechanism, that my knee joint is feels like that it is locked and it needs certain kind of manipulation to be unlocked, in that kind of patients you might be thinking about the meniscal tear. Again joint line tenderness will be there. So if medial meniscus is involved, so medial joint line pain and medial joint line tenderness will be there. Then we have the swelling, again that is very much confined to your medial joint space, and difficulty in squatting and painful clicking will be there. So in some patients you might feel that the clicking sound is not painful, but in the meniscal tear, especially in the radial tear and the horizontal tears, they will feel a clicking sound while doing the activity. Again the chief complaint of the patient will be knee get stuck or clicks. So this is the first thing that patient will tell you, that my knee feels like it is being stuck and I need certain kind of maneuver or manipulation to unlock it, and then painful while bending. Okay, so there will be no pain while walking or going upstairs and downstairs, but rather than while bending the knee there will be pain. Now then we have is the ACL injury. So you see, in ACL injury there will be instability. So again, ACL injury is a traumatic event, especially in the while playing the football, where the athletes might have ACL injury. Now there will be instability in the knee joint. Okay, especially the anterior translation of tibia will be there. The patient will complain of you giving away, as if the knee is giving away onto the anterior aspect. Then immediate swelling will be there. So the moment ACL is being torn, there will be immediate swelling, which is also known as your hemarthrosis. The collection of blood will be there, and difficulty in pivoting. Pivoting means shifting to the side on side. So there will be difficulty in the pivoting. Now the patient chief complaint will be knee give away during the sports activity. So there is not having a stability in the knee joint. Again, the knee joint will be swollen and it will be unstable, and we definitely know we have special tests like Lashman test, anterior draw test is there for checking the ACL integrity. Then we have is the PCL injury, which is the posterior cruciate ligament, in which there will be posterior knee pain. So again, in Baker's cyst also we have is the posterior knee pain, but in PCL there is a history of trauma. Okay, then difficulty in descending the stairs. So in a patient who are suffering from PCL injury, they will be having difficulty while moving downstairs, and there will be sag sign. So I will attach an image somewhat over here about the sag sign. So whenever you check both the tibias in the 90-degree bend of the knee flexion, you will see the injured tibia, or where we have is the PCL injury, that is looking like moreover dip towards the inferior aspect. Okay, and then again the instability will be there in the knee joint. Now the patient chief complaint will be knee give away again during the sports, as the ACL again swollen and unstable. So we definitely have a different special test, like the posterior draw test and the sign that we talked about, that is your sag sign, you will be checking. We have the another ligament injury, that is your medial collateral ligament injury. Now in this medial knee pain will be there. Okay, tenderness along the medial joint line will be there, and valgus stress pain will be there. So whenever we talk about the special test, we definitely do the valgus stress testing. So I will also attach the image over here, in which we pull the knee joint towards the outer aspect, or the tibia towards the outer aspect, and there is bilateral asymmetry will be there onto the both medial aspects. So if there is a greater distance, like 2 to 3 mm difference will be there in medial valgus stress test, that means it is positive for your MCL injury. In this kind of patient, you also take a very detailed history about from where the force has come while during the sports activity, because there is a high velocity force injury in these kind of ligament tears. So definitely you should be asking your patient. Now then we have is the LCL injury, which is your lateral collateral ligament injury. Now there will be lateral knee pain, tenderness and instability in the varus stress test. So again, just opposite to the MCL, now we do the varus stress test. So I'll be putting the image over here. In this you will find that it is more 3 mm more than the contralateral side while doing the stress test, and then again it is positive for your LCL injury. Pain on the outer aspect of the knee and unstable sideways. So there will be a sideways instability in the knee joint. Then we have is the osteoarthritis, again a degenerative kind of condition which is very common. So we have is the morning stiffness, okay, which is less than 30 minutes, because if it is more than 30 minutes, that means you should be thinking about any kind of infectious arthritis, okay, or you can think about the rheumatoid arthritis, because if it is less than 30 minutes, the stiffness is there, that means it is suggesting us towards the more degenerative kind of disease. Then again the crepitus will be there. It can be on the patellofemoral aspect or the femoral tibial aspect. Then we have the swelling. So swelling around the knee joint is very common, and varus or valgus deformity can be present in grade 3 and grade 4 OA, and there will be reduced range of motion along with the pain. So these patients also have pain while doing the range of motion exercises. Now knee pain and stiffness will be there definitely, and worse with the walking, and as the age progresses, the degenerative condition moreover moving forward. Then we have is the rheumatoid arthritis. Now you see, before moving on to the rheumatoid arthritis diagnosis, you should be checking the family history. You should also be checking the small joints and the bilateral involvement, because there is bilateral involvement in the rheumatoid arthritis. then definitely bilateral knee pain will be there, prolonged morning stiffness will be there, more than 30 minutes like we talked about, and swelling will be there, and different kind of systematic symptoms will be there in the body. Now you see, whenever we talk about the bilateral knee pain, which is very uncommon in the osteoarthritis, okay, mostly it is towards your one knee joint, the unilateral knee joint, but in rheumatoid arthritis bilateral involvement is there. So you should be checking these kind of things, both knee painful and stiff, the patient will tell you, and especially in the morning more than 30 minutes. If it is less than 30 minutes, that gets better after walking, that is suggesting you osteoarthritis. And definitely you should be also looking at the different lab reports and lab testing for the rheumatoid arthritis, like your RF factor will be there, okay, anti-CCP test, your C-reactive protein and ESR will be high. Okay, and then we have is a very important thing, which is your Baker's cyst, which is present at the posterior aspect of your knee, which is your popliteal fossa, and again it can be present in between your semimembranous and your gastrocnemius muscle head. So you should be looking at the medial surface and the medial joint space also onto the posterior aspect. Now posterior knee swelling will be there, tightness and possible calf pain if it is ruptured. So you should be also looking at how much big cyst is present inside your patient. If it is a moderate to severe kind of cyst, in that case you should avoid any kind of strenuous activity and knee flexion, okay, because that might capture your Baker's cyst and it will be ruptured. In that kind of patients, the patient will be having an intense pain, and some might also feel like that the entire calf region is being clogged, and as if someone has placed a tourniquet on that aspect. So it is a very a serious pathology. If it is small Baker's cyst, so you have to understand the Baker's cyst does not come alone, okay, it is secondary to some other problem. So the root cause will be either your meniscal tear which is not being healed or treated, or it can be a degenerative changes in the knee joint. That is why we are getting the fluid accumulation on the posterior aspect of the knee, okay. And also you should be checking while pressing the popliteal fossa with both of your thumbs to compress this lump which is present onto the posterior aspect, and definitely patient will complain you about the pain, okay. Swelling and tightness behind the knee, that is very common, and you should not use hot packs in these kind of patient. Rather than you should be focusing on the cryotherapy or ice massage. Ice massage will help better these kind of patients, okay. Again, the final diagnosis is made through the MRI, not the X-ray, you should remember. Then we have is the bursitis, that can be present on the prepatellar surface, that is your anterior aspect of the knee, infrapatellar below the patellar region, or pes anserine, that is present onto your medial aspect of the knee joint. So whenever we talk about the pes anserine, what exactly which tendons are coming over there, okay. So we have three tendons, so three muscles, SSG, remember SSG, that is your semitendinosus, sartorius and gracilis. So these tendons are inserting over that aspect onto the inner surface of your knee joint, that is your medial aspect, and there they can have a bursitis. Now, so the localized swelling will be there in the bursitis. You will see the warmth of the joint will be there, tenderness and difficulty in kneeling. So while doing the kneeling activities, these patients will definitely have the pain. Even if you check the pes anserine, that is the medial aspect of the knee joint, so you will feel that the moment you will press that area, there will be pain, okay. Even if you stretch that area, there will be pain in these kind of patients. So you should be avoiding these stretching kind of exercises on the very first day if you suspect the pes anserine or any kind of bursitis, okay. You should be focusing on rest and giving some cryotherapies in that region. Now the chief complaint will be swelling and pain at front inner aspect of the knee. So according to the location of bursitis, there will be swelling and pain. Next up we have is the iliotibial band, that is your IT band syndrome, okay. Again onto the outer, the lateral aspect of your thigh region. So lateral pain will be there, that is worse while running and doing cycling kind of activities. Tenderness over the lateral femoral condyle, so you will be checking the lateral femoral condyle, there will be tenderness onto the insertion point. And there is one more point that I want to include. The moment you will ask your patient to do the SLR, okay, so if there is a IT band syndrome, you might see in 0 to 30 degree while the patient is lifting the leg, that there will be an external rotation in the first phase of your SLR. That might tell you that either your lateral compartment muscles are overacting, over hyperactive, or your IT band syndrome is present. So you should be looking these kind of things. Again, the chief complaint will be pain onto the outer aspect of the knee joint while running or doing the cycling kind of activity. So now we are going to talk about your chondromalacia patellae. We have already talked about the patellofemoral pain syndrome, but now it is your chondromalacia patellae, in which the articular cartilage behind the patella is wean off, and there is a articular damage, and there is a friction between the distal femur and the retropatellar space, in which there will be anterior knee pain. So again, the pain will be referred to the anterior aspect of the knee, it is not onto the posterior aspect. Crepitus will be there while doing flexion and extension of the knee joint, pain while doing stair climbing and squatting again. And in this kind of patient, you might also see that there is a difference, bilateral difference in the quadricep muscle. Okay, you might also see the atrophy of the VMO muscle in the patients who are dealing with the chondromalacia patellae. So you should be addressing the VMO strengthening in these kind of patients. And the chief complaint will be grinding pain under the kneecap. Okay, so patient will tell you that there is someone grinding my knee joint as if. So again, chondromalacia patellae will be there. So the next pathology that we are going to talk about is your patellar dislocation or the subluxation. Now in these kind of patients, the moment you will check the patellar apprehension test, that is pushing the patella laterally or medially, they will not allow you to, the moment you will try to dislocate it, they will contract their quadricep muscle as a protective mechanism. So this is the first thing that you will see. There will be a acute lateral shift, or it can be a medial shift. Swelling will be there. Apprehension, like I talked about, that will be present, and recurrent instability, that is the complaint of your patient will be having. Then the kneecap slipped out. See, the chief complaint will be there, kneecap is slipped out, and painful and unstable knee joint the patient will complain about. So the next pathology that we are dealing with is your Osgood-Schlatter disease. Now you have to remember some of the few things and features that you will see in your patient while doing the assessment. First of all, they will be young adults, male and female. Second thing, they will be active in sports. The third thing, there will be a anterior knee pain they will complain about, and the tenderness will be present at the tibial tuberosity. So you can see pain and swelling at the tibial tuberosity will be there and worsen with the activity. So the moment you will be the patient will be putting load on that area, there will be pain. And if you are not treating the Osgood-Schlatter disease, that will again become the tendinopathy. So from tendinitis it will become tendinopathy. And in Osgood-Schlatter disease, there is a chipment of the tibial tuberosity. So the patellar tendon does a chipment of a small fracture from the tibial tuberosity that you will see in the X-ray itself. The chief complaint will be pain below the kneecap, especially after the sports activity. Okay, now we have is the Siding-Larsen-Johnson disease, that we call it as a SLJ in short form. So in OSD there will be a pain at the tibial tuberosity more, and the tenderness will be present. But if you compare with the Siding-Larsen-Johnson disease, there will be pain at the inferior pole of the patella. And like we have discussed about OSD, that the chipment will be from tibial tuberosity, but in SLJ there will be a chipment from the inferior pole of the patella in the X-ray. Again, as you can see, tenderness will also present at the tibial patellar tendon area. And again, the chief complaint will be pain just below the kneecap during the sports. Okay, then we have is the stress fracture. It can be on tibia, femur, or around the knee joint. So whenever there is a loading phase, prolonged loading phase due to the occupation, we see or deal with these stress fractures. So there will be a localized pain worsen with the activity. So the moment patient is doing his routine activity, in that kind of time they will be having pain. Tenderness on the palpation onto the bony aspect, not any other region. Then deep knee pain will be there after running, or that gets better with the rest. In these kind of patient, they will also feel better with the cryotherapies, and some might feel better with the warm water soaking on submersion with the salts in it. So these kind of thing will be present. Then we have is the synovitis. So in synovitis, as you can see, the inflammation is there, the synovial area. So diffuse knee swelling will be there. Again, the temperature will be high onto the knee aspect. So if you compare the bilateral knee joint with both of your hands, you will definitely see the difference in the temperature and pain with the movement. So throughout the range of the movement, they will have pain from the initiation of the movement. In osteoarthritis, you see there is a certain kind of range after that pain comes on, but in the synovitis there will be a pain throughout. Swelling and pain will be there inside at the whole around the whole knee joint area. Okay, So the last pathology that we are dealing with is your gouty arthritis in knee involvement, but it's very common. They are found onto your MTP joint, the first big toe area of your foot. But you see, whenever there is a collection of the uric acid in that kind of patients, there will be a gouty arthritis. Sudden severe pain will be there. Again, the temperature will be high and swelling will be there. Then the chief complaint of the patient will be severe knee pain with this swelling, and there is a sudden onset. In degenerative kind of conditions, there is a gradual onset, but in gouty arthritis there is sudden onset of the pain. So that is from my side. If we have missed any kind of pathology in the knee joint that you want to learn about, then do let me know in the comment section. And if you like the video, do not forget to subscribe my channel, and thank you for watching.